Good morning, guys. Today we start talk about disease of thyroid glands, and I call this lection a thyroid. The thyroid gland lies in the lateral triangle of the neck. The thyroid comprises two lateral lobes, an isthmus, and a pyramid, schematically increased as a bilobed shield. Bilobed isthmus. The function of the follicular cells is to produce, store, and release the thyroid hormones thyroxine, T4, and triiodthyronine, T3. The function of the C cells is to produce the calcium-lowering hormone calcitonin. Disease affecting the thyroid gland can generally be grouped into disorders of thyroid function, including hypothyroidism and thyrotoxicosis, or disorders affecting thyroid structure, including nodular goitre and thyroid neoplasms. Disorders of both function and structure may coexist. A goiter refers to enlargement of the thyroid and is a term applicable regardless of the cause of the enlargement. However, from the surgical point of view, a classification of thyroid disease can be considered as comprising the following groups: thyroglossal duct cyst, benign thyroid nodules, multinodular goiter, thyroid cancer, thyroid toxicosis, thyroiditis. Disorders of the thyroid gland. There you see all types. Thyroglossal duct cyst is the first group of disease what we will discuss in. There in the picture you see the thyroid gland and you see this duct and you see the cyst. Thyroid follicular cells arise from the region of the foramen cecum at the junction of the anterior 2/3 and posterior 1/3 of the tongue, and during embryological development the gland descends in the midline to the level of the larynx, where it buds laterally. A contribution of neural crest cells arising from the fourth bronchial cleft and the ultimobranchial body gives rise to the C cells of the thyroid as well as to a small projection from the posterolateral surface, the tubercle of Sackerlandel. As the thyroid gland descends during embryological development, remnants of thyroid tissue may be left behind anywhere along the thyroglossal tract. Occasionally, some respiratory epithelium may be included in the remnant, resulting in a thyroglossal duct cyst. A non-cystic benign thyroid nodule or even thyroid cancer may also develop anywhere along the tract. Embryological descent may also continue into the anterior mediastinum, giving rise to a thyrothymic thyroid remnant. The junction of the thyroglossal duct tract and the isthmus of the thyroid gland marks the site of the pyramid, a variable-sized projection superiorly of thyroid tissue. Clinical presentation. Thyroglossal duct cyst usually present in childhood or adolescence, but may occur at any age. However, in elder patients, the possibility of papillary thyroid cancer in a developmental remnant should be considered as an alternative diagnosis to a de novo thyroglossal duct cyst. The usual clinical presentation is that of a midline swelling at or just below the level of the hyoid bone, often slightly to one side of the midline. Classically, the swelling elevates with protrusion of the tongue. Inflammation may give rise to an abscess or a fistula. The diagnosis of a thyroglossal duct cyst is usually self-evident on clinical examination. Fine needle aspiration cytology will confirm the nature of the cyst contests, also this may precipitate inflammation. Cytology will often show colloid cholesterol crystals and benign epithelial cells. Aspiration may be therapeutic as well as diagnostic with resolution of the cyst. FNAC is important for excluding the uncommon papillary thyroid cancer arising in a thyroglossal duct cyst. Neck ultrasound to confirm the presence of a normal thyroid gland and thyroid function should be undertaken. Treatment is surgical excision through a skin crease incision. The cyst and the thyroglossal tract must be removed, which involves excision of the mid portion of the hyoid bone and tracing of the tract to its upper limit. Failure to remove the full extent of the tract will result in recurrence of the cysts or a discharging sinus. The next topic what we will discuss is benign thyroid nodules. Pathology. Between 30 and 40% of clinically solitary thyroid nodules will present a dominant nodule within an underlying multinodular goiter. Of the remainder, the majority will be benign nodules, comprising simple thyroid cysts, solitary colloid nodules, or benign follicular adenoma. Approximately 7% will be thyroid cancer, and the further small group will represent an area of nodularity within thyroiditis, both Hashimoto's and subacute. Apart from rare developmental inclusion thyroid cysts, the majority of thyroid cysts form following hemorrhage into an underlying benign thyroid nodule, which then matures into a thyroid mass consisting of a rim of thyroid tissue and a central liquefied area. Colloid nodules and hyperplastic nodules should be considered part of a similar pathological spectrum. The most common presentation of a single thyroid nodule is that of an asymptomatic swelling in the neck. The characteristic clinical feature of a thyroid nodule is that it elevates on swallowing because the thyroid is enveloped by the pretracheal fascia which attaches to the trachea. This will distinguish a thyroid nodule from a lymph node swelling adjacent to the thyroid which does not elevate and on swallowing. Benign thyroid nodules may also present with local pressure symptoms. These include dysphagia from esophageal pressure, breathlessness, or stridor from tracheal pressure, a hoarse voice from pressure on the recurrent laryngeal nerve, or superior vena cava obstruction from a large single nodule obstruction the thoracic inlet. A toxic nodule will present with symptoms of thyrotoxicosis. Regional lymphadenopathy should always be sought. Increasingly, thyroid nodules, which may or may not be palpable, are identified incidentally on imaging such as ultrasound, CT, MRI, or positron emission tomography undertaken for investigation of other symptoms, for example neck pain and carotid artery studies. Thyroid function tests including thyroid stimulation hormone, free T4 and free T3 should be performed in all patients to exclude subclinical thyrotoxicosis. Suppressed TSH will be seen in association with normal free T4 and free T3 levels, or to diagnose a toxic nodule or toxic adenoma. Ultrasound is routinely performed to establish underlying multinodularity and to characterize the features of the nodule. Features raising an element of suspicion as to the nature of the nodule includes solid as opposed to cystic internal vascularity as opposed to peripheral vascularity. Microcalcification dimensions tailorer than wide and irregular of outline. Fuzzy abnormal lymph nodes may be identified by ultrasound. FNAC needle aspiration is a definitive investigation, and the possible cytological reports are, are categorized in table 37.1. This Bethesda classification is widely used worldwide. FNAC should only be undertaken after exclusion of thyrotoxicosis, as a toxic adenoma may appear concerning on cytology. Further, toxic adenomas are almost always benign. It is important to note that cytology may suggest a follicular neoplasm but cannot differentiate between a benign follicular adenoma and a follicular carcinoma. This diagnosis can only be made by the finding of either capsular or vascular invasion on histology, hence the need for diagnostic hemithyroidectomy in these patients. The likelihood of a follicular lesion on cytology being malignant is up to 30%. Needle aspiration is best performed with ultrasound guidance in order to target the most appropriate part of the nodule and to ensure the nodule of concern is biopsied. An inadequate or non-diagnostic aspirate is not a benign result and should be repeated, as up to 10% of this will be malignant. The excitation here is a thyroid cyst on clinical and ultrasound features, where FNAC shows colloid, cyst fluid, and degenerate cells only, and where overall the features are consistent with a thyroid cyst. Also, strictly, there is no epithelial material to diagnose a benign thyroid nodule. FNAC may be therapeutic as well as diagnostic for thyroid cyst, and repeated aspiration will result in resolution in at least 50% of cases. FNAC may also show features of thyroiditis alone or in combination with other cytology. Hashimoto's will show lymphocytes, and subacute thyroiditis may show inflammatory cell and giant cells. The role of nuclear medicine scans is limited to the investigation of patients with thyrotoxicosis or thyroiditis. Treatment. Asymptomatic thyroid nodules that are benign on FNAC do not generally require treatment. However, follow-up at least in the short term is appropriate. Indication for surgery includes the presence of obstructive symptoms, thyrotoxicosis, of the finding of malignancy, suspicion of malignancy or atypical of follicular changes on FNAC, and on patient request. The minimal surgical procedure is a hemithyroidectomy, removing all thyroid tissue on the site of lesion. Thyroxine suppression is ineffective in decreasing the size of single thyroid nodules. Multinodular goiter. Multinodular goiter occurs as a result of repeated cycles of hyperplasia, nodule formation, degeneration, and fibrosis occurring throughout. The gland. It occurs either in response to iodine deficiency or in iodine-replete areas as a result of the intrinsic heterogeneity of TSH receptors. The latter has a high familial incidence. A dominant nodule within a multinodular goiter is most likely to be either a hyperplastic or colloid nodule. However, the incidence of malignancy in a dominant nodule is approximately the same as for a single nodule. Hence, multinodular goiter has a high familial incidence and is also common in areas where iodine is deficient in the diet. Most multinodular goiters present as an asymptomatic mass in the neck. They may also present with local pressure symptoms to the trachea, esophagus, recurrent laryngeal nerve, or SVC. Clinical retrosternal extension and Pemberton's sign should be assessed and lymphadenopathy sought. Thyrotoxicosis complicating the goiter is also common, especially in the elderly with large goiters. An otherwise asymptomatic retrosternal multinodular goiter may present incidentally as a mass on a chest X-ray or CT scan. Thyroid function test, as previously outlined, must be performed on all patients. Ultrasound will document the site of the thyroid lobes and the number and size of nodules, providing a baseline for follow-up, and will also indicate which nodules require FNAC. FNAC of a dominant nodule or nodules aims to exclude malignancy, and the CT scan will assess retrosternal extension or tracheal compression and deviation. Intravenous contrast is avoided because of its iodine content and the possibility it may precipitate iodine-induced thyrotoxicosis. A thyroid nuclear medicine scan is used in a multinodular goiter to assess for a solitary toxic nodule or multiple areas of variable activity. Indication for surgical treatment of a multinodular goiter includes the presence of obstructive symptoms, growth of the goiter, thyrotoxicosis, suspicious or malignant changes on FNAC, a strong family history of thyroid cancer, the presence of retrosternal extension, a past history of head and neck irradiation, and patient request. In a young patient with large multinodular goiter who is otherwise asymptomatic, thyroidectomy may also be considered for cosmetic reasons. The only effective treatment is surgical excision. If surgery is undertaken, total thyroidectomy is the preferred option because it removes all tissue likely to cause symptoms and avoids the possibility of lateral recurrence, which occurs in about 30%. Lifelong thyroxine replacement is required after total thyroidectomy. Thyroid cancer. Thyroid cancer is a bigger topic, and for this lection I don't want to give you much information, but I will give you a small information what will help you in your next education in the oncology. Thyroid cancer can arise from the follicular cells, the C cells, or other cells such as lymphocytes or stromal cells, each giving rise to a different form of thyroid cancer. Papillary thyroid cancer accounts for about 85% of thyroid cancers, tends to occur in a younger age group, is often multifocal, spreads predominantly to local lymph nodes, and has a relatively good prognosis, with 10 years survival rates of at least 90%. Follicular cancer occurs in an older age group, 40-60 years, arises as a single tumor metastasis via the bloodstream and has a worse prognosis than papillary cancer with 10-year survival rates around 75%. Together, papillary and follicular thyroid cancer are considered differentiated thyroid cancer and account for the majority of thyroid cancer, resulting in the usual overall good prognosis. The incidence of PTC is increasing worldwide at an exponential rate, particularly for tumors less than 4 cm in diameter. Further, there is an increasing recognition of micropapillary thyroid cancer, which is often an incidental pathological finding in a goiter removed for other reasons, usually multinodular goiter. Anaplastic or undifferentiated thyroid cancer occurs in the elderly, often presents as a rapidly enlarging diffuse mass, spreads locally, and has a very poor prognosis with 5-year survival rates of less than 1%, but is fortunately very rare. Malignancy rising in C cells gives rise to medullary carcinoma of the thyroid. This tumor secretes calcitonin and may be part of a familiar multiple endocrine neoplasia (MAN2A) syndrome occurring in association with pheromocytoma and hyperparathyroidism. The 10-year survival rate is around 35%. Lymphoma of the thyroid is thought to arise in lymphocytes, often in association with pre-existing Hashimoto's thyroiditis. Follicular-derived thyroid cancer has an association with previous exposure to ionizing radiation. Thyroid cancer commonly presents as either a single thyroid nodule or a dominant nodule in a multinodular goiter. It occasionally presents as a metastasis as an abnormal lateral lymph node in the neck, hence the need to undertake FNAC and all abnormal lymph nodes prior to removal. Thyroid cancer may also rarely present as distant metastatic disease, such as bony metastasis from follicular cancer or lymphangitic lung involvement from papillary cancer. Thyroid function test and neck ultrasound will assess the nodule and possible abnormal lymph nodes. Depending on presentation, the most useful investigation is needle aspiration, but CT is of value in determining extent of tumor and lymph node involvement. Serum calcitonin levels may be raised in medullary tumors. Treatment. Most differentiated thyroid cancer is still treated by total thyroidectomy with local removal of involved lymph nodes. Following removal of the tumor, patients are classified into those with low, intermediate, or high-risk tumors on the basis of age, tumor size, lymph node involvement, extrathyroidal extension, and distant metastasis. We will show it in the next slide. In the right side, you see the algorithm. First of all, we see thyroid nodule in the sonography, for example. It is less than 1 cm, suspicions finding in ultrasounds no, follow up after 12 months. Yes, follow up after 3 or 6 months. No growth, follow up after 12 months. It grows. Fine needle aspiration biopsy. Follicular neoplasia suspected malignancy clearly malignant. Do the surgery. The next one, more than 1 cm, TC99M scintigraphy, no sign of autonomy, fine needle aspiration, follicular neoplasia surgery. And multinodular goiter, scintigraphy, no sign, free needle aspiration, follicular neoplasia surgery. Yes, and classification of tumors: high, intermediate, and low risks. High risk growth, extrathyroidal extension, incomplete tumor resection, distant metastasis or lymph node more than 3 cm. Intermediate risk, aggressive histology, minor extrathyroidal extension, vascular invasion, or more than 5 involved lymph nodes. Low risk, intrathyroidal differentiated thyroid cancer with 5 or less lymph node micrometastasis. Subsequent treatment may involve the administration of radioactive iodine for moderate or high-risk cancers, which allows for both the detection and ablation of metastatic disease. Following total thyroidectomy, thyroxine replacement is required lifelong, and for high-risk cancers is given in a larger dose to suppress TSH. Low-risk papillary cancer may include young patients with tumors less than 4 cm in diameter and with absent extrathyroidal extension or lymph node or distant metastasis. In this setting, consideration for treatment by hemithyroidectomy alone is appropriate, also total thyroidectomy is considered an equally appropriate treatment option. For tumors of less than 1 cm micropapillary PTC with no other risk factors, hemithyroidectomy alone is considered adequate treatment. Close follow-up is essential, and fuzzy surgery for lymph node recurrence and use of radioiodine usually results in a good prognosis. Newer agents such as tyrosine kinase inhibitors are available for widespread disease, also rarely required. Medullary thyroid cancer requires total thyroidectomy and a central lymph node dissection with lateral neck dissection and mediastinal clearance for node-positive patients. Medullary carcinoma does not respond to radioiodine ablation. Thyroid lymphoma is best diagnosed by multiple core biopsies or occasionally an open incisional biopsy. It is then usually treated by chemotherapy and occasional radiotherapy. It often responds well to these treatments. Thyrotoxicosis. It is not the disease, it is the syndrome. The cause of thyrotoxicosis include Graves' disease, toxic nodular goiter, Plummer's disease, toxic follicular adenoma, or in the initial stage of thyroiditis, may occur in both Hashimoto's and subacute. Rare causes include a TSH, secretin, pituitary tumor or struma ovary. Graves' disease is an autoimmune condition associated with antibodies to the TSH receptor. Toxic nodular goiter results from autonomous activity in a neoplastic nodule. Thyrotoxicosis presents with symptoms and signs of thyroid overactivity, including tachycardia, hot intolerance, sweating, fine tremor, weight loss, and anxiety. In addition, Graves' disease may be associated with exophthalmos, ophthalmoplegia, and a pretibial myxedema. Graves' disease typically produces a smooth diffuse goiter, which because of significant blood flow may exhibit a palpable thrill and bruit. Toxic nodules may also present with local pressure or obstruction. The diagnosis of thyrotoxicosis will be confirmed by a thyroid function test with an elevated free T4 and or free T3 in association with a suppressed TSH. Clinical examination may indicate the etiology, demonstrating a diffuse goiter, a multinodular goiter, or a single thyroid nodule. Thyroid nuclear scans will confirm the diagnosis as well as the etiology and exclude infections, thyrotoxicosis, and thyroiditis. Anti-TSH receptors antibodies are present in Graves' disease and are quantified as a measure of severity and response to medical treatment. And there I want to show you the types of thyroid toxicity. Normal uptake looks like the left upper, Graves' disease central upper, thyroiditis Hashimoto's right, autonomous nodal Plummer's, and multinodular goiter. Initial treatment is to render the patient euthyroid by administration of antithyroid medication such as carbimazole or propyltyrosine, both of which prevent coupling of iodotyrosine. Patients with Graves' disease are generally treated with medication for 12-18 months. Definitive treatments for Graves' disease include ablation with radioactive iodine, usually reserved for patients over 14 years of age because of the theoretical teratogenic risk of total thyroidectomy. Graves' disease is treated by surgery if there is relapse following initial medical treatment, or non-compliance with such treatment, or if ophthalmopathy is present, in which case radioiodine ablation is contraindicated, as radioiodine may induce worsening ophthalmopathy. Toxic multinodular goiter and toxic adenoma are best treated surgically once the patient is rendered euthyroid by anti-thyroid medication in order to treat the thyrotoxicosis and remove the goiter. Thyroiditis, the next syndrome what I want to tell you today, is classified as lymphocytic Hashimoto's, subacute decorations, and acute bacterial or fibrosing radicals. Of these, two most common are lymphocytic, which is an autoimmune condition often forming part of a spectrum with Graves' disease, and subacute, which is a post-viral phenomenon. The other two are rare. Clinical presentation. Lymphocytic thyroiditis may present with hyperthyroidism early phase or hypothyroidism late phase, or it may present with a nodular or diffuse goiter. Subacute thyroiditis usually presents with an exquisitely tender and large firm thyroid gland with nodularity, often with systemic symptoms of headache, malaise, and weight loss. The history is relatively short, usually of several weeks duration, and the nodularity may sequentially involve different areas of the thyroid. Initial thyrotoxicosis may also be present. Thyroid function test will determine the level of thyroid activity. A nuclear medicine scan is often diagnostic, showing patchy uptake in lymphatic thyroiditis and no uptake at all in subacute thyroiditis. The inflammatory markers erythrocyte sedimentation rate and C-reactive protein will be elevated in subacute thyroiditis but not Hashimoto's. Antiperoxidase and anti-thyroglobulin antibodies will be elevated in Hashimoto's but not subacute thyroiditis. Treatment. Subacute thyroiditis usually responds to high-dose steroids and aspirin therapy. Also, it may take 3-6 months to fully resolve. Lymphocytic thyroiditis may respond to thyroxine suppression. Yeah, and there you see the algorithm. Yeah, subacute thyroiditis treatment, mild symptomatic SAD, non-steroidal anti-inflammatory agents, beta-adrenergic blocking drugs. No improvement, resulting of pain, median time 5 weeks, and corticosteroids. Moderate to severe pain and or thyroxic symptoms, corticosteroids or prednisolone in dose 40 mg in 1-2 weeks or 15 mg daily. Gradual tapering over 2-4 weeks on longer tapering by 5 mg every 2 weeks. Surgery may be required for lymphocytic thyroiditis with persistent or suspicious nodules or for pressure symptoms. Also, surgery may be more difficult because of the solid, non-pliable nature of the gland. Yes, and the last one, what I want to tell you today, it is operative management thyroidectomy. Thyroidectomy is indicated for relief of local pressure symptoms, for the diagnosis and treatment of thyroid cancer, for the control of thyrotoxicosis, or for cosmetic consideration as previously outlined. Thyroidectomy may be total or partial. Complications of hemithyroidectomy. The complications of hemithyroidectomy include all the general complications of any operation, such as bleeding, wound infection, and reaction to the anesthetic agent. In addition, there are specific complications. They include postoperative neck hematoma, damage to the recurrent laryngeal nerves, damage to the external branch of the superior laryngeal nerves, damage to the parathyroid glands. Hematoma. Postoperative hemorrhage causing a neck hematoma is a major surgical emergency requiring urgent return to theater and decompression and occurs in 1-2% of cases. Enlarging hematoma beneath the strap muscle layer will result in increasing pressure, in turn causing venous and lymphatic obstruction and submucosal edema of the larynx and trachea, and potential critical airway obstruction. Treatment is urgent, relies on the pressure by opening the skin and deeper strap muscle layer. Usually there is time to transport the patient to theater, but occasionally it is more rapidly involving and will need to be performed on the ward. Hence the need for close observation of the neck postoperatively and a thyroid tray of instruments at the patient's bedside should they be required. Unilateral recurrent nerve palsy leads to a hoarse voice and is usually temporary, often resolving within weeks but occasionally taking up to 6 months, and occurs in up to 10% of cases. Recurrent laryngeal nerve palsy may be permanent in 1–3% of cases. And there you see the laryngeal nerves in anterior position. First of all, you see the arteries in superior thyroid, right vagus nerves, inferior thyroid artery, right recurrent laryngeal nerve, it is left recurrent laryngeal nerve, and you can see that it goes not the same like in the right side. Left vagus nerves, external laryngeal nerve, internal laryngeal nerve, and superior laryngeal nerve. And of course, it's very easy to damage all of them, because sometimes we have not this anatomy and we have some variants. Voice quality usually improves over time, but occasionally can be improved further by procedures such as vocal cord medialization. Rarely, bilateral damage may occur and require a tracheostomy because the vocal cords adopt a medial position, causing airway obstruction. And there you see some another variants of anatomy. If the external branch of the superior laryngeal nerve is affected, the patient may lose the ability to sing, shout, or project the voice. Because of postoperative change and edema at the site of surgery, up to 80% of patients will experience subtle alteration in their voice quality in the absence of either recurrent or external laryngeal nerve injury. This change often takes several months to resolve. Parathyroid glands. Permanent damage to the parathyroid glands will cause permanent hypoparathyroidism and occurs in 1–3% following total thyroidectomy. Temporary hypoparathyroidism causing temporary hypocalcemia is much more common, usually 8–12% of cases, but may be even commoner and is due to edema, bruising, devascularization, or inadvertent removal of parathyroid glands. Treatment is short-term administration of oral calcium and 1,25 dihydroxyvitamin D for several weeks, but occasionally intravenous calcium is required. These complications are avoided by understanding the surgical anatomy of the thyroid gland and by the technique of a capsular dissection, carefully preserving the parathyroid glands and their blood supply, and the recurrent laryngeal and external laryngeal nerves. If there is devascularization of parathyroid glands or inadvertent removal, they should be auto-transplanted. That's all what I want to tell you today, guys. Thank you very much for your attention and be healthy. Bye bye. See you on the practice.